Welcome back to the deep dive. We take complex information, boil it down, and give you what you need to know. Today, we're diving into antepartum hemorrhage, or APH. Sounds technical, I know.
Yeah, but it's fundamentally about bleeding late in pregnancy, after the 28-week mark, basically.
Right. And our mission today is to unpack what that means, what causes it, and importantly, how medicine has really improved things here. Outcomes are so much better now.
Absolutely. And what's fascinating, I think, is how you can have similar symptoms, bleeding, but they point to totally different conditions.
Like different root causes.
Exactly. And each needs its own specific management plan. Understanding why they're different is crucial.
Okay, so let's nail the definition first. APH, bleeding from or into the genital tract after 28 weeks, but before the baby's born.
Mm-hmm. And it happens in, what, about 3% of hospital deliveries? So not incredibly common, but significant.
Definitely. And the main culprits we hear about are Placenta Previa and Abruptio Placentae.
Those are the two big ones, yeah. Plus, there's sometimes a group where the cause isn't immediately obvious, but those two account for a large chunk. And just a reminder, we're exploring these medical conditions purely for understanding. This isn't medical advice.
Right. Good point. Okay, let's dig into the first one. Placenta Previa. This is where, as you said, location is everything for the placenta.
That's the perfect way to put it.
So what happens when this lifeline, the placenta, just implants in the wrong spot?
Well, placenta previa means the placenta has implanted low down in the uterus, so low that it's partially or even completely covering the cervix, the internal os, technically.
The baby's exit route.
Exactly. Previa just means in front of. It's literally in front of the exit. It accounts for maybe a third of APH cases. Incidence is somewhere around 0.5% to 1% of hospital births.
And are certain people more likely to experience this?
Yeah, we tend to see it more often in women who've had several babies already, multiparous women. Also, mothers over 35, pregnancies with high birth order, and multiple pregnancies like twins. But it's also interesting that better family planning, with spacing out births, seems to have helped lower the overall rate a bit.
So why does it happen? Why does the placenta implant low?
Well, there isn't one single definitive answer, but there are theories. One idea, sometimes called the dropping down theory, is that the fertilized egg just implants lower down than usual. Maybe the upper part of the uterine lining, the decidua, wasn't quite as receptive.
Okay.
Another thought is about a defective decidua. If the lining isn't ideal, the placenta might need to spread out more to get enough surface area for nutrient exchange.
Spread out wider.
Right. And sometimes the spreading can lead to it reaching the lower segment. In some rare serious cases, this can also mean it attaches too firmly, digging into the muscle. That's placenta accreta, increta, or percreta, which is a whole other level of complication. Makes removal really dangerous.
Wow. So beyond just where it initially implants, what other factors increase the risk? You mentioned age and having multiple babies.
Yeah, those are key. Multiparity, definitely. Being over 35, that's like a 4-fold increase in risk.
4 times.
Yeah. Race seems to play a role sometimes. Some studies mention higher rates in Asian women. Also, things like infertility treatments.
And scarring.
Oh, absolutely.
Yeah.
Any previous scar on the uterus is a big risk factor. So previous C-sections, operations to remove fibroids, myomectomy, hysterotomy, even previous DNCs or curettage.
So basically any previous uterine surgery.
Pretty much. And having had placenta previa before increases the risk for future pregnancies. Multiple pregnancies, like twins, again, and even smoking.
Smoking, how does that?
It seems to cause placental hypertrophy. The placenta gets bigger, likely to compensate for lower oxygen levels caused by carbon monoxide. A bigger placenta might be more likely to reach down low.
Got it. Now, I know there used to be different types, like type I, type 2. How is it classified now? Is it simpler?
It is simpler, thankfully. Organizations like ACOG and ACR updated the guidelines back in 2014.
Yeah.
Now, we mainly differentiate between true placenta previa, where it actually covers the internal os.
Covers the opening.
Right. And low-lying placenta, where the edge is close within 2 centimeters, but not actually covering it. It's a more practical distinction for deciding how to manage things.
Okay. And I've heard the term dangerous placenta previa. What makes it particularly dangerous? Is it just about bleeding?
That's a really important point. It's not always just about the bleeding risk, although that's obviously there. A dangerous previa often refers to one that's positioned on the back wall of the uterus, a posterior previa.
Why is the back wall worse?
Because it can physically block the baby's head from descending into the pelvis. Imagine the placenta filling that space.
Ah, so it prevents engagement.
Exactly. which means the baby's head can't act like a natural tamponade, pressing on the lower segment to help control bleeding after delivery. Plus, it increases the risk of the umbilical cord getting squeezed or even prolapsing during labor.
Which cuts off the baby's oxygen.
Precisely. It can lead to fetal anoxia or worse. So that posterior location adds mechanical risks on top of the bleeding risk.
So what actually triggers the bleeding itself?
It comes down to how the uterus changes in late pregnancy. The lower part, the lower uterine segment, starts to stretch and thin out, getting ready for labor.
Right.
But the placenta implanted there, it's not stretchy, it's inelastic. So as the uterine wall stretches beneath it, the placenta gets sheared off slightly.
Like peeling tape off a curved surface.
That's a good analogy.
Yeah.
And that shearing action tears the blood vessels connecting the placenta and uterus, and that causes the bleeding. It's often called inevitable because it's sort of a mechanical consequence.
You mentioned even an examination could trigger it.
Yes, any trauma, even sometimes just a vaginal exam, if done inappropriately, can disturb that attachment and provoke bleeding.
Okay, I have to ask about placental migration. Does the placenta actually move upwards?
Yeah, that term is confusing. It's a bit of a misnomer. The placenta itself doesn't physically relocate.
So what's happening?
Well, if you diagnose a low-lying placenta early, say at the 20-week scan, most of them, like over 90%, won't be low-lying by the time of delivery.
Wow, 90%?
Yeah. It appears to migrate away from the cervix. But what's really happening is twofold. First, the lower uterine segment undergoes massive growth and stretching between 20 weeks and tenfold expansion.
So the uterus grows away from the placenta's edge.
Exactly. The uterine wall stretches upwards, effectively pulling the lower segment, and thus the cervix, away from the stationary placental edge. Second, there's something called trophotropism. The placental tissue tends to grow preferentially towards the top of the uterus, the fundus, where the blood supply is richer.
So it grows upwards and the bottom part stretches away.
That's the idea. So it looks like it moved, but it didn't really pack its bags.
Okay, that makes sense. So if someone does have placenta previa and experiences bleeding, what are the classic symptoms doctors look for?
The textbook description is pretty specific. The bleeding is usually sudden. It's painless. It's a key feature. Yes. And it often seems causeless, like it happens out of the blue, maybe even during sleep. And it tends to be recurrent. The first bleed might be quite slight, kind of a warning shot, but later bleeds can be much heavier.
And when you examine the patient?
Generally, her overall condition, like pulse, blood pressure, signs of anemia, they match the amount of blood you can actually see that's been lost.
Okay.
And when you feel the abdomen, the uterus itself feels soft, relaxed, elastic, not tender. You might notice the baby isn't head down, maybe breech or transverse.
Because the placenta's in the way down there?
Exactly. The head is often high, floating, not engaged in the pelvis. But crucially, you can usually still hear the baby's heartbeat.
So given the risk of triggering massive bleeding, how do you confirm the diagnosis safely? You mentioned not doing a vaginal exam.
Absolutely. That is rule number one, the cardinal rule. No vaginal examination outside of an operating room equipped for an immediate C-section. Period.
Non-negotiable.
Completely. Any bleeding in the second half of pregnancy, you have to assume it could be placenta previa until proven otherwise, and act accordingly to ensure safety first. Provoking hemorrhage with an exam is a disaster.
So how do you prove it otherwise? What's the method today?
Ultrasound. Sonography is the way. It's simple, it's incredibly precise, and most importantly, it's safe. It lets you see exactly where the placenta is located relative to the cervix.
Do you scan over the belly?
Yes. Transabdominal ultrasound, TAS, is usually the first step. But transvaginal ultrasound, TVS, is actually even more accurate for seeing the relationship between the placenta and the internal os. And it's safe. The probe doesn't need to go near the cervix itself to get a clear view. It's considered virtually 100% accurate.
And you can see other things too, like blood flow.
Yeah, adding color Doppler helps assess blood flow patterns. This is especially useful if you suspect placenta accreta, where those abnormal vessels might be growing into the uterine wall.
Is MRI ever used?
Sometimes, yeah. For complex cases, like a tricky posterior previa, or definitely if accreta is strongly suspected, MRI gives amazing detail, and it's non-invasive, but it's more expensive and obviously not portable like ultrasound.
So these modern imaging techniques sound like they've completely changed the game.
Oh, massively. The advantages are huge. Number one, we avoid those dangerous vaginal exams.
Right.
Number two, we can often diagnose it before any significant bleeding even happens, sometimes just on a routine scan, which means less need for long, anxious hospital stays just waiting.
And you mentioned accreta.
Yes. Number three, Being able to diagnose or strongly suspect placenta accreta before delivery is absolutely critical. It allows for meticulous planning, getting the right surgical team, blood products ready, counseling the patient. It makes a potentially life-threatening situation much more manageable.
It sounds like it really improves safety. But what are the potential complications, even with good management, for the mother?
Well, bleeding is still the major risk before labor, during labor or C-section, and postpartum hemorrhage, PPH, is also a significant concern. There's also, as we mentioned, higher rates of malpresentation, premature labor, cord prolapse. Labor might not progress well, the need for C-section is much higher, and sometimes, if bleeding is uncontrollable, especially with accreta, a hysterectomy might be unavoidable to save her life.
Accreta sounds incredibly serious.
It is. It's a major cause of maternal morbidity and mortality associated with Previa. And of course, if the mother is anemic to begin with, even moderate blood loss can quickly lead to shock.
And what about the risks for the baby?
For the fetus, the risks include being born prematurely, which brings its own set of complications. Low birth weight, fetal growth restriction, FGR, can occur perhaps due to suboptimal placental function even before major bleeding. Asphyxia, or lack of oxygen, is a risk during bleeding episodes or cord accidents. Sadly, intra-anterorator is possible, and there's even data suggesting a higher risk, threefold, of congenital malformations, though the reasons aren't fully clear.
So, given all these potential issues, how is it managed once diagnosed in the hospital?
Well, ideally, prevention starts earlier with good antenatal care, checking and correcting anemia, and routine ultrasound screening. But if bleeding occurs, the first steps at home are immediate bed rest and assessing the loss.
Then straight to hospital.
Absolutely.
Yeah.
All APH cases need hospital admission. Once there, it's a rapid assessment. How much blood loss? Get blood drawn for grouping, cross-matching hemoglobin levels. Start an IV line with fluids like normal saline, a gentle abdominal feel, and just inspect the vulva for ongoing bleeding. Still no internal exam.
Okay. Then what? Is it always immediate delivery?
Not necessarily.
Yeah.
This is where the two main management strategies come in: expectant versus active, or definitive management.
Expectant sounds like waiting.
Exactly. Expectant management aims to buy more time for the baby to mature, provided the mother remains stable and safe. This is only an option if you have blood readily available 24/7 in immediate access to C-section facilities.
Right. The safety net has to be there.
Totally. The criteria would be: mother is stable, hemoglobin is decent, say above 10 G%, pregnancy is not yet term, less than 37 weeks, there's no active significant bleeding, and the baby seems well on monitoring.
And what does expectant management involve?
Strict bed rest, regular checks of mother and baby, investigations, maybe iron supplements. If the pregnancy is less than 34 weeks, we typically give corticosteroids to help mature the baby's lungs in case early delivery becomes necessary.
Okay. And active management. When is it time to deliver?
Active or definitive management means proceeding to delivery. This is indicated if bleeding occurs at or after 37 weeks, if the patient goes into labor, if she's bleeding heavily or showing signs of shock, if moderate bleeding continues despite trying expectant management, or if there are any concerns about the baby's well-being, or if the baby has sadly passed away or has a known severe abnormality.
And how is the delivery usually done? You mentioned C-section.
Yes, cesarean delivery is the standard approach for the vast majority of placenta previa cases now. Certainly if the placenta covers the os, or is within 2 centimeters, or if it's a posterior or particularly thick placenta.
So vaginal delivery is pretty much off the table.
It's very rarely considered. Only perhaps if ultrasound shows the placental edge is clearly far away, like 2 to 3 centimeters minimum, from the internal os, and there are other favorable factors. But even then, it's approached with extreme caution, and remember, still no risky vaginal exams beforehand. The shift towards C-section has dramatically improved safety.
And with placenta accreta, what's the specific plan there?
Accreta requires a whole extra level of planning. Diagnosis confirmation might need that 3D Doppler or MRI. Management absolutely needs a multidisciplinary team: senior obstetricians, anesthetists, neonatologists, blood bank specialists, sometimes urologists or general surgeons if invasion is suspected.
Because removal is so difficult?
Exactly. The placenta is abnormally stuck, maybe invading muscle. Trying to remove it can cause catastrophic hemorrhage. So the plan often involves delivering the baby via C-section, potentially leaving the placenta in place initially, and then proceeding to a planned hysterectomy to control the bleeding.
Wow.
Hysterectomy. It's often the safest course in severe accreta, though sometimes, in select cases, other techniques like leaving the placenta to resorb over time or using interventional radiology to block blood vessels uterine artery embolization. Might be attempted to preserve the uterus, but hysterectomy is common. Careful surgical technique during the C-section, like choosing the incision site to avoid the placenta, is also vital.
Okay, let's shift gears now. The other major cause you mentioned was abruptio placentae.
Right. Also known as accidental hemorrhage or premature separation of a normally situated placenta.
So the placenta is in the right place, but it separates too early.
Precisely. Bleeding occurs because a normally implanted placenta starts detaching from the uterine wall before the baby is born.
And this can present differently.
Yes, there are different varieties. Revealed abruption is most common. The blood tracks down between the membranes in the uterine wall and escapes through the cervix, so you see external bleeding.
Okay.
Then there's concealed abruption. Here, the blood gets trapped behind the separating placenta, forming a clot. You might see little or no external bleeding, but there can be significant internal blood loss and uterine tenderness. This form is often more dangerous because the extent of the hemorrhage isn't obvious.
In danger.
Exactly. And then there's mixed, which has features of both. It's important to note the bleeding is almost always maternal blood. Fetal bleeding is rare unless there's a tear in the placenta itself.
And how common is abruption?
It happens in about 1% of deliveries, roughly 1 in 100. It's a major cause of perinatal mortality, stillbirth, or newborn death, maybe 15–20% risk. And also maternal mortality, though lower, around 2,000%. It accounts for about 30% of APH cases overall.
So what's actually happening inside the uterus during an abruption?
It starts with bleeding into the deciduo bassalis, that lining layer under the placenta. This forms a clot, a decidual hematoma, which expands and separates more of the placenta.
And it can affect the uterus muscle itself?
In severe cases, yes. Blood can extravasate or seep between the muscle fibers of the uterus. This can lead to a condition called the cuvulare uterus, where the uterus looks bruised, purplish, or port wine colored because it's infiltrated with blood.
Does that mean the uterus is permanently damaged?
Surprisingly, not necessarily. While it looks traumatic, a cuvulare uterus often still contracts effectively after delivery and doesn't automatically require a hysterectomy. The main danger is the systemic effect of the abruption, the blood loss, the potential for shock, and coagulation problems.
Coagulation problems. You mean like DIC?
Exactly. Disseminated intravascular coagulation, or DIC, is a really serious complication, especially with severe or concealed abruption. The placental separation releases tissue factor, thromboplastin, into the mother's circulation, which triggers widespread clotting.
So it causes clots?
It does, but it uses up all the clotting factors, like fibrinogen and platelets, in the process. So paradoxically, the mother then loses the ability to form clots where she needs to, leading to uncontrollable bleeding. It's a consumptive coagulopathy. Very dangerous.
What makes someone more likely to have an abruption? What are the risk factors?
The single most important association is hypertension in pregnancy. Preeclampsia, gestational hypertension, chronic hypertension, they're linked in maybe 10 to 50% of cases.
Why hypertension?
The underlying mechanism is thought to involve spasm and damage to the small spiral arteries in the placental bed, leading to rupture and bleeding.
Okay, what else?
High parity, having many previous babies. Advancing maternal age. Poor socioeconomic status or nutrition. Smoking is also a factor, likely due to vasospasm again.
Any physical triggers?
Yes, trauma is a definite risk. Car accidents, falls, even sometimes procedures like forceful external version to turn a breech baby, or amniocentesis if the needle hits the placenta.
What about changes in the uterus?
Sudden uterine decompression, like after the first twin delivers, the uterus suddenly shrinks, potentially shearing off the remaining placenta. Or if there's polyhydramnios, too much amniotic fluid, and the membranes rupture suddenly, that rapid decrease in volume can cause separation. Other things include a short umbilical cord, cocaine abuse, certain clotting disorders called thrombophilias, and importantly, having had an abruption before significantly increases the risk, maybe 5–17% recurrence.
Okay, so clinically, how does abruption present? How is it different from the painless bleeding of Previa?
It's usually a very different picture. The classic symptom is the sudden onset of abdominal pain, often described as constant severe pain. This is often followed by vaginal bleeding, although remember in the concealed type, bleeding might be minimal or absent.
Pain is key then.
Pain is a major feature. And the signs are different too. The mother's general condition, shock, pallor, rapid pulse, is often much worse than you'd expect from the amount of visible blood loss, especially if it's concealed.
Because of the internal bleeding.
Exactly. And when you examine the abdomen, the uterus feels very different from Previa. It's typically tense, tender, and rigid, sometimes described as woody hard or board-like.
Rigid and tender, okay.
And tragically, because the placenta is separating and the baby's oxygen supply is compromised, the fetal heart sounds might be irregular, show distress, or be absent altogether. Preeclampsia is also frequently present alongside abruption.
So, quick comparison. Previa is often painless bleeding, soft uterus, baby usually okay initially. Abruption is typically painful bleeding, rigid tender uterus, maternal shock, potentially out of proportion, and fetal distress is common.
That's a very good summary of the key differences, yes. The nature of the pain, the feel of the uterus, and the degree of shock versus visible loss are critical distinguishing points.
And the complications of abruption sound severe.
They are, yes. Maternal morbidity and mortality are higher than with Previa. Shock from hemorrhage, that dangerous DIC we talked about, acute kidney injury or renal failure due to poor blood flow in DIC, and severe postpartum hemorrhage are major maternal risks.
And for the baby.
The fetal risk is generally much higher and more immediate in abruption than in Previa. The sudden separation severely compromises or completely cuts off oxygen and nutrients. Fetal distress is common, and the risk of intrauterine death is substantial, especially in severe or concealed abruptions, sometimes reaching 50 to even 100%. Pre-existing placental issues, often associated with conditions causing abruption, like hypertension, mean the fetus might already be compromised.
So, how is abruption managed? It sounds like time is critical.
Time is absolutely critical. Prevention focuses on managing risk factors like hypertension, avoiding trauma, being cautious with procedures that could cause sudden decompression. But once it happens, immediate hospital management is key.
Similar initial steps. Assessment for blood tests.
Yes, rapid assessment of blood loss, vital signs, getting IV access, drawing blood for cross-match, hemoglobin, and crucially, coagulation studies including fibrinogen levels and arranging blood transfusion.
And then, is it always delivery straight away?
Definitive treatment, which is delivery, is almost always the goal and often needs to happen urgently. The mode and timing depend on the severity, maternal stability, fetal status, and gestational age.
So C-section usually.
If the mother or baby is unstable, or if labor isn't progressing quickly and the fetus is alive but distressed, then yes, immediate cesarean section is often the safest route.
What if she's already in labor?
If the mother is stable, the bleeding isn't torrential, and she's already in labor, sometimes labor can be accelerated. Performing an amniotomy, artificially rupturing the membranes, can sometimes help.
How does breaking the waters help?
Two ways, potentially. It allows the fetal head to come down and press more directly on the placental site, helping to compress bleeding vessels. And it might reduce the amount of thromboplastin getting squeezed from the damaged placental site into the mother's circulation, possibly lessening the risk or severity of DIC.
Is expectant management ever an option with abruption? Like waiting?
Very, very rarely. It might only be considered in extremely specific mild cases, usually diagnosed after a small bleed that is completely stopped, where the mother is totally stable, the fetus looks well on monitoring, and the pregnancy is quite preterm. But it requires incredibly close monitoring and is not common practice for acute abruption. The default is usually delivery.
And managing those complications like DIC and shock?
That's paramount. Aggressive fluid and blood product resuscitation to treat shock. If DIC develops, treatment involves replacing the consumed clotting factors, fresh frozen plasma for factors like fibrinogen, cryoprecipitate, which is rich in fibrinogen, and platelets if needed. Managing potential kidney failure might involve careful fluid balance and sometimes dialysis.
Okay, so those are the big two. You mentioned sometimes the cause isn't clear, indeterminate bleeding.
That's right. Sometimes, even after delivery and examining the placenta, we can't definitively pinpoint the cause of bleeding. It wasn't Previa, it wasn't a clear abruption, it just remains unexplained.
Are there any other specific, less common causes?
Yes, one important one to mention, though rare, is Vasa Previa.
Vasa Previa, what's that?
This is where fetal blood vessels, unsupported by the umbilical cord or placental tissue, run through the membranes right over, or very close to, the internal cervical egg.
So the baby's own blood vessels are exposed at the exit.
Exactly. And the danger is that when the membranes rupture, either spontaneously or artificially, these unprotected vessels can tear.
And that would be fetal blood loss.
Yes, catastrophic fetal blood loss. Because the baby's blood volume is so small, even a small tear can lead to rapid exsanguination and fetal death very quickly. Fetal mortality is tragically high, around 50% or more if it's not diagnosed before rupture.
Can you diagnose that beforehand?
Thankfully, yes. Color Doppler ultrasound during pregnancy can often identify these vessels crossing the cervix. If Vasa Previa is diagnosed antenatally, The management is usually a planned elective cesarean section before labor starts and before the membranes rupture, usually around 34 or 36 weeks. This dramatically improves fetal survival.
So, pulling all this together, looking back at how these conditions were managed versus now, the progress seems incredible.
It really is night and day, especially for placenta previa. Maternal mortality has plummeted from significant levels historically to less than 1% in many places, sometimes even approaching zero in well-resourced centers.
What made the biggest difference?
It's a combination of things. Early and accurate diagnosis with ultrasound is huge, critically abandoning routine internal vaginal examinations in suspected cases. The ready availability of safe blood transfusions, effective antibiotics to prevent infection, the much wider and safer use of cesarean section when indicated, and just overall more expert obstetric and anesthetic management and neonatal care.
But challenges remain.
Oh, absolutely. Particularly in low-resource settings where access to ultrasound, blood banks, safe surgery, and skilled personnel might be limited. Outcomes are still much poorer in those areas. And it's worth remembering, both previa and abruption carry an increased risk of happening again in a future pregnancy, so vigilance is needed.
That brings us to the end of this deep dive. We've covered a lot, unpacking antepartum hemorrhage, focusing on the two main players, placenta previa and abruptio placentae. We've seen how they differ in cause, presentation, and management, and crucially, how modern medicine, especially imaging, has shifted the landscape from dangerous diagnostic methods to safer, earlier detection and intervention.
It really makes you think, doesn't it?
Mm-hmm.
So maybe a question for you, the listener. Considering how understanding the specific mechanisms and, importantly, the diagnostic shifts for these conditions has so drastically improved safety, how might that change your perspective on the power of technology combined with critical thinking in advancing modern obstetric care?
That's a great point to reflect on. It's a powerful illustration of how evolving medical knowledge and the tools we develop can truly revolutionize outcomes and protect both mother and baby. Thank you for joining us for this deep dive. Until next time, keep digging into what truly informs you.